first of all, let me introduce everyone who's present here. So we have Dr. Dhableshwar Sahu, who is acting as the chairperson for this virtual program from Pratima Hospital. And we have Dr. Ignacio with us. Good morning. He's coming directly from Argentina with a very rich experience. So it's morning there. And we have Dr. Siddharth Mani from NH. So he'll be acting as the second speaker. The first speaker will be Dr. Ignacio, and Dr. Sao will be acting as the chairperson, as I already said, very experienced. With now coming to the panelists, we have Dr. Priyank Modi with us. Dr. Shrivat Sanardik from NH Moga, Dr. Priyank from Sanjeevani Hospital, Surat, and we'll be joined by Dr. Pradeep Pereira and Prashant Pawar shortly. We also have Dr. Kishli Srivastav from Apollo Sage Hospitals, Bhopal. So, good evening to everyone. So, the event will start. I'll just give a short presentation from Translumina's side, post which we'll be having a case presentation and discussion by Dr. Ignacio, and then we'll move to Dr. Siddharth. So, that will be the order of the event. And after each event, we'll be pausing to take notes and exchange whatever comments we have for the. So I'll just share my screen and start with the corporate presentation. Just a quick presentation, just to make everyone on the same page on what Translumina is all about. Is it visible?
It's not visible. Yeah, it's visible now.
Visible now?
Yeah.
Yeah. So at Translumina, we are committed to explore limitless possibilities. That is the motto of the organization. So if I give a brief about the organization, we are focused on interventional cardiology. Unlike many other medical device organizations, our focus is purely on interventional cardiology. We started in 2000. We are present in 70 plus countries. We have 3 global manufacturing facilities and 2 indigenous manufacturing facilities right here in India. And we have a close collaboration with the German Art Center, who also partner with us for the R&D excellence. Multiple projects, all the coating technologies regarding drug eluting stents have come from the German Art Center. We have other strategic partnerships with multiple organizations for exclusive marketing rights in India. Coming to our drug eluting stents, we are very proud to present that our drug eluting stents are the part of 3rd generation drug eluting stents, and we have a robust clinical data of 10 years. One of the most longest studied drug eluting stents are with Translumina at the point. We have CE certified products since we do business both in India and Europe. And we have a proud accomplishment of over 1 million implants as of now. Now, coming to the recent developments with the organization, we recently acquired Blue Medical, since drug eluting balloons are all the rage nowadays. So Blue Medical was already a pioneer in Europe, and they had a drug eluting balloon known as Protege, and it was having some unique technologies. So we acquired the company recently, and we are also marketing the product now in India as well, bringing the same product over here. We also acquired Lamed GmbH recently, who are doing very well in vascular accessory market and vascular products in Germany. And coming to our flagship brands, VivoSR, which is the world's first polymer-free drug eluting stent using Probocol and a unique microporous surface along with shellac resin, and using a cobalt chromium platform. So the sirolimus and Probocol combination is something unique that we are offering. It's a safer way to deliver the stent, and we have rich clinical data of 10 plus years with this product. And we also have some workhorse balloons, since stents need the support of workhorse balloons to get the angioplasty done under the range of Optima SC and Optima NC that we are marketing exclusively in India. One point that we have differentiated from other workhorse balloons is that we have a tractor strip, which is very atraumatic and does very well even in complex lesions, tortures and cuts. So that's all from my side. I'll stop sharing and hand over the platform to Dr. Ignacio.
Hello, good evening to all. Can you hear me well?
Yeah, you can see your slide. Yes.
Okay, we can start.
Okay, thank you very much for the invitation to participate in this important webinar focused on polymer-free DES in complex PCI. My name is Ignacio Cigalini. As mentioned, I'm an interventional cardiologist from Rosario, Argentina. For you to know, this is where I am. It's a large city in Argentina, mainly known by it's the birthplace of some of our icons, the flag, or maybe you will know these two more. Lionel Messi was born here, as well as Angel Di Maria. So, well, back into business, and the idea of this talk is to talk about the journey from balloon angioplasty to polymer-free drug eluting stents. This is a long journey with almost half a century old. We are long from the homemade catheters in Andrea Grutznik's kitchen, and we have advanced towards near perfection, I would say. We all know that this ride was exciting and had presented with several twists and turns. For instance, the development of balloon angioplasty was a milestone that had developed breaking through in a new specialty, it's interventional cardiology, but was associated with several issues, mainly acute vessel closure and an acceptable in-stent restenosis rate of about 30% that eventually resulted in the development of scaffolds. However, the problem was still not solved because there was still an important development of severe diffuse in-stent restenosis, which led to the development of antiproliferative drugs. However, this first generation DES came across with some other difficulties, mainly driven by an important increase in very late stent thrombosis because of the delayed healing and the inflammation resulted from the polymer that carried the drug. So we were very happy with the development of newer generation drug eluting stents. However, we still know that there are main challenges with these polymer-based drug eluting stents. There are still aggressive inflammatory reactions during polymer erosion that are known to cause persistent fibrin deposition, delayed endothelialization, chronic inflammation, persistent platelet activation, and perturbativity. All of this associated with late arterial healing, late and very late stent thrombosis, and obviously with some compliance depth that are very important in a subset of patients, like patients with high bleeding risk. So we also know that current polymer are associated with flaking, peeling, and webbing, which leads to impaired action of the drug. Long been discussed in different conferences. Greg Stone, many years ago, asked in the TCT that we needed better stents to further eliminate early and late stent thrombosis and restenosis, reduce the dependency on long-term DAB, and to improve lifelong prognosis after DES. And he proposed several items which, not surprisingly, are incorporated in the main features of the Vivo ISAR platform, and the struts thinner and eliminating the polymer. As previously mentioned, Vivo ISAR is the world's first drug polymer-free DES. It's the longest study polymer-free DES with randomized controlled trials with follow-up up to 10 years, which is pretty interesting. And I would like to highlight some important features of this unique design. As mentioned, this stent has a micropore surface, which is created with sandblasting. This is a special characteristic used to enhance the delivery of a longer duration of the drug. These micropores act like reservoirs to control the release kinetics of the drug, and we know that these structured surfaces show a better and faster endothelialization when compared to with flat surfaces. Obviously, the queen of the prompt in this stent is the use of Provocol as a component of the stent coating matrix for like an alternative to the polymer. due to its high lipophilicity, the protocol ensures optimal release kinetics of sirolimus, and also its potent antioxidant effect has enhanced anti-restenotic efficiency with proven effects in a study performed with balloon angioplasty, where propofol led to a significant reduction in luminal diameter loss compared to placebo, and as well as a significant reduction in restenosis rates and repeated angioplasty in this first technique of plain balloon angioplasty. Some important features in this platform is the abdominal coating with shellac resin. This leads to directional drug release to target tissue with less systemic exposure of the drug, which leads to faster healing. And also the shellac resin prevents dual drug matrix breaks up during the stent expansion. Last but not least, the main component of the drug is the sirolimus, which has a well-studied and clinical proven immunosuppressant effect with anti-proliferative and immunosuppressive effects. Another important technical specifications of these platforms relies on its thickness. It's a thin stent, but with no compromise of its radial strength and flexibility, with a better visibility and trackability thanks to its cobalt chromium alloy. Also, its open cell design has enhanced possibilities to side branch access in coronary bifurcations, but we all know it's a very frequent problem to address. Almost 20% of our PCI cases are performing bifurcation lesions. So obviously, all these attractive features need to be validated in clinical trials, and it's very important to highlight that this platform has several publications along the years with preclinical studies demonstrating ideal drug release kinetics for better anti-restenotic efficiency compared to polymer-based and conventional polymer-free stents, with 80% of the drug released in 28 days as compared with other platforms. But mainly, and the most important thing, is the established safety and efficacy with long-term follow-up, 10 years clinical data. This is a study published a couple of years ago in JACC, where patients with coronary disease were randomized to be treated with this platform and compare with durable polymer revolutionizing eluting stents. In this unique long-term analysis at 10 years, the EVO-ISAR polymer-free stent showed similar efficacy and safety profile as sirolimus eluting stents, both in device-oriented composite endpoints and patient-oriented composite endpoints, with a very low stent thrombosis rate of 1% at 10 years. This study was also important because it made us possible to understand the stent in different higher risk substrates. For example, in acute coronary syndrome, where no difference was found comparing this polymer-free versus permanent polymer DES. However, a trend and a numerically reduction, but not significant, was seen when analyzing patient-oriented composite endpoints in the higher risk population of acute coronary syndrome and STEMI patients. This numerically, but not statistically significant reduction in events was also seen in another higher risk population, which is diabetic patients, when all of the events were numerically inferior but not significant, mainly due to its nature. This is a non-inferiority trial, but it's important to highlight that in diabetic patients, we see in these Kaplan-Meier curves a quick diversification of the curves, which are sustained, and the trend towards lower MACE and all-cause mortality, but not insignificant. But this, I believe, that should be taken into caution, but it's interesting information for us to highlight. So enough theory, let's go to some practice. This webinar was to discuss this platform in complex PCI. Although we don't have a standard definition for complex PCI, we all know that there are some criteria regarding the anatomy of the patient or the patient itself and its comorbidities and the equipment use. So I will try to give some of examples in some complex PCI settings to see how these stents develops. This first case is a bifurcation with 2 stents in a high bleeding risk patient. This is a 67 years old male with chronic heart failure with severe ejection fraction, with atrial fibrillation, with high bleeding risk requiring, as you see, the occlusion of the left atrial appendage. This patient had a real bifurcation compromise in the left circ and the first obtuse marginal branch with calcified side branch lesion. So an upfront 2-stent technique was planned. We used a DK crush technique in this upfront 2-stent technique with predilatation of both main branch and side branch. We started to deploy Vivo ISAR in the side branch at 2.516, and with a more aggressive post-dilatation, it's important to highlight this is the place where restenosis occurs in bifurcation lesions, so we have to prepare the ostium of the same branch very well. After assuring no distal dissection was seen in the side branch, we removed the wire and performed the first crush, then rewire the side branch and perform the first kissing, and deploy in the main branch another Vivo ISAR through the marginal branch. Then the first pod, the second kissing balloon, and a final pod to see a very good angiographic result. And the patient did well. Short dab concerning his bleeding risk was performed with no bleeding nor thrombotic complications at follow-up. Another case with complex PCI or chronic total occlusion. This was a 47 years old male who had been admitted recently for an extensive anterior STEMI, which required PCI to LAD. He had a remaining CTO of RCA, as you can see, with good collaterals from the septal branches. Initially, we tried to go antegrade, but unfortunately, we weren't successful. So we tried retrograde, and this is a samurai wire over a microcatheter, allowing for a successful retrograde approach. This is the predilatation of the vessel, and now we're going to see an IBUS run, long diffuse disease with calcium, which was eventually treated with 2 Vivo ISAR stents. This is the IBUS run after the deployment of the stents, which show the stents well opposed and well expanded, with some malapposition in the proximal segments that you will see here, which was corrected with a post-dilatation with a bigger balloon. And this is the final angio, the stents implanted. And finally, last case of another bifurcation lesion, this an ostial LAD lesion in a young woman, which presented with an NSTEMI after stressful events. She presented with anterior negative T waves and a mild to moderate reduction in her ejection fraction. Here you can see an eccentric stenosis in ostial LAD in this young woman with no significant cardiovascular risk factors. We would like to rule out a type 3 spontaneous coronary artery dissection, so we perform an OCT run, which demonstrated a fibrillipid plaque in ostial LAD, opposite to the side branches, unfortunately. So we discussed this patient in our heart team and decided endovascular approach through a femoral 7 French approach. In this case, we performed the procedure with IBUS. Here you can see the same, an eccentric fibrillipid plaque opposite to the same branch in the ostium of LAD. To optimize the procedure, we also did some runs to the ramus and to the left circ, which showed no disease in these 2 branches. So a provisional stenting approach was decided using a Vivo ISAR 3.5 to 28 millimeters from the left main to LAD after plaque preparation with cutting balloon. we performed pod. Here you can see the balloon size of the pod was undersized, and because of the pod puff sign, it was positive. You can see flow in the 3 branches. So an adequate pod was performed using a 4.5 NC balloon. And we rewire both side branches and perform tracing, and a final pod to correct the deformation in the stent. These are the final IVOS runs from LAD, and also from both branches, the left circ, showing no compromise of left circ ostium, and from Ramos. And this is the final angiographic result in this young woman, with no events on her follow-up. So in conclusion, I believe that this new generation polymer-free stent, as the VivoISAR, has no polymer-related side effects, with optimum drug release kinetics with protocol, and it's very reassuring to have 10 years of proven safety and efficacy in general, but also in some substrates of high-risk patients such as diabetics and acute coronary syndromes. So thank you very much for the invitation, and I hope all this information and cases were for your interests.
Okay. Thank you, Dr. Ignacio, for nice presentation. 3 cases with bifurcation, first one. Then second one is your this OCT demonstration with second one CTO, and third one is OCT with the IVOS. Nice presentation. And regarding this non-polymer, initially we started with persistent polymer with degraded polymer. Now it is polymer-free concept. As you demonstrated the VivoISAR, the polymer is, initially told the polymer is essential level, because if polymer, the drug release will be predictable and adequate. Simultaneously, it told it will cause delayed inflammation that leading to inflammation that leading to
Recording in progress.
Okay. So that will cause also late stent thrombosis. That is the only. Okay, nice presentation. And with the next speaker, Dr. Siddharth.
Before that, any other comments from any panelists regarding the cases that we saw before we move to the next presentation? Dr. Priyank or Dr. Krishna, Dr. Srivatsa? Anything that you want to ask regarding?
Nice to see you.
I was.
Yeah, it was nice presentation. I just wanted to know the expansion limit of distance, because I think there was a left main case demonstrated. What is the expansion limit for these stents, VivoISAR? Say what 3.5 can go up to what millimeter?
So our expansion limits go up to 4.5. A 4 mm stent that we have the approved limit goes up to 4.5.
3.5?
4.5 is the maximum limit. Yeah. So we're underway working on some designs in which we'll be adding some connectors to gain higher diameter. But as of now, 4.5 is the prescribed over expansion limit.
Many a times we have a LED which is 3 mm and 5 mm left main. I think in
Right.
Be,
So in many cases, I've seen doctors take it and use it, and just as a approved limit in terms of the CE regulations is 4.5.
Okay.
But I've seen many users, taking it to higher diameters with confidence.
I think in this case, Dr. Ignacio used it from left main to LED. Am I right?
I beg your pardon? Can you repeat?
I think you stented from left main to LED in one of your cases. No?
Then third case.
The last case, yeah.
Last case.
The last case was was a stent through the left main to the LAD. It was a 3.5 stent and was post-dilated in the left main with a 4.5 NC balloon. The left main was right
Did we do
that side. I agree with Manish. We know the limit recommended, but sometimes we tend to go and leave the stent well opposed. It
Here
would
I
be
would
very
like to
put the results of this overexpansion it's a very important feature in bifurcation lesions. So yes, I completely agree with you and I agree in this kind of question.
Yeah, one problem is when we post-dilate beyond the recommended limit. That means, say, if you go beyond the recommended limit, sometimes it might lead to deformation of the stent. I think if you had done a post OCT run, did you do it, sir? Post?
Yeah, I did a post IVUS run because I used OCT when I did the diagnostic angiogram, but to perform the PCI, it was guided with IVUS. So I have IVUS result there with no longitudinal deformation of the stent. The stent was well opposed, but I know that IVUS has not the same spatial resolution as IVUS.
Okay.
So that's matter.
Thank you.
Sir, I would like to. I would. Hello.
Yes.
Yeah. Sir, so I'll just discuss my experience because we've done like good 50 cases plus left main left main crossovers with Vivo ISA. So my first case was of a general practitioner whom I had to do a left main to LED where I underestimated the expansion and then I had to expand a 410 to 5.5. So I was really worried about how things are going to go. So next day we did at that point of time we did not have an IVUS in the lab and we did a next day run. And there was no gross stent deformation even when I had expanded it to 1.25 millimeter of what the baseline diameter was. After that, we have had like at least 7-8 cases where we have expanded till 1 millimeter plus, so 3.5 to 4.5 or 4 to 5. And grossly, there has been no gross stent deformation. After that, the confidence has been so much so that I don't now do a post IVUS in every case where I have to go at least 1 millimeter up front. The only context here is they don't have the data, and maybe with the existing cell design only, if they collect data, they should be good enough. Similar of what happened to the Zions group, like later on the Alpine and everyone, where they found later on when they did that the same design did not really had a problem when the expansion was done.
I think I'd like to add one point here. If you're truly looking at, say, stent fractures or deformation, OCT is better because deformations and fractures are seen or better on OCT. IVUS can tell you about apposition and final area and all that. But I think as far as stent deformation is concerned, OCT will be better. Coming to your point that going beyond 1 mm, although it is okay in certain cases, especially when we use ox balloons, I have seen many stents when we go beyond the recommended limit, they tend to fracture. If you do an OCT, you will see that there will be fractures. Although in the long run, it will not have much clinical implication, but definitely stent deformation can occur. Say, for example, if you go at 3 to 5.5, not in Alpine, another stents I'm talking. So, and if you do an OCT, you'll definitely see some stent fractures. Clinically, it may not lead to any long-term complication, but definitely it can cause some deformation.
Regarding, I have got a doubt. When you expand almost a millimeter or more than that, go beyond the stent limits, do you go in a stepwise manner, like 0.5 millimeter, or then go to 1 millimeter dilatation, or on a single balloon you go 1 millimeter or 1.25 millimeter in one go?
There is no need for stepwise dilation. If you have a 3.5,
because as we saw that stent deformation is an issue, whether it is prudent to go stepwise and
it is basically related to the balloon size, right? So whether you go stepwise or whether you go in one go, if deformation has to occur, it will occur. So I think if you are doing in left main, just doing it in one go is, whatever size you want, 4.5, 4. I don't know how others will feel, but if in left main there is no need to go in a stepwise manner. Basically, you are not expanding here, but rather opposing. So opposing need not do at a stepwise manner. This is not an expansion. This is correcting the malopposition.
Okay.
Okay. Regarding just lower size stents, suppose 2.75, 2.5 stents. How much will go?
Yeah.
Left main is okay. If you 3 mm stent, you can expand it 3.5 or 4. It will not cause any problem. Suppose you want to suppose bifurcation, just before bifurcation, one way branch, big branch is coming, and there is a long stent you are putting. So definitely there is a distal vessel maybe 2.5 and proximal will be around 3.7. So while putting long stent, always there is a discrepancy. So, regarding 3 mm stent, you can go 3.5, 4. But 2.5, 2.75 stents, how much will go? Can you go up to 3?
I think 3.5 you can go.
3.5.
Yeah.
But
275 can go up to 3.5.
3.5. But
See, I mean, it is not about the Dr. Sahu. It is not about the diameter of the stent, but the tubings. I think the 2.25, 2.5, 275, they come in one this one expansion limit. 3.5, 4, 4.5, they got like that.
Expansion limit, that is smaller stents has lesser expansion limit. Then higher stents is 3.5 you can go 4.5. Because smaller size stents, that is 2.5, 2.7 have limitation.
They can go to 3.5.
Manish, you can explain.
So basically, Dr. Srivatsa is correct that when the stents are manufactured, so basically they are cut from these metallic tube meshes. So these sizes are limited when they are manufactured, and after the laser cutting has been done, it is at that time then the process comes into play in which size it has to be crimped. So a 2.75 stent on paper might go to 3.5, but if it's cut out of the same mesh and of the same size, so those are the same tubes that are used for the 4 and 4.5 as well. And when you go to smaller vessels, then you use a different cutout mesh, which is usually for your 2.25, 2, and the smaller size.
Smaller size.
So basically, there are only 2 or 3 tubes which are used for all the sizes, and this is not just for translumina. All stents are made this way, right?
Correct.
Yeah. So the crimping part and the chemical processing is where we control which size we are crimping it to, so that it's more suitable for expansion. But you can usually use the medium vessel sizes for all medium vessels when you're expanding. Right. So if any more comments are there, we can discuss, or we can move to Dr. Siddharth.
Okay.
Anything specific to the cases? Anything left, or we can move?
One thing is the left main, when you are the sizes of stent is more 4.5, you cannot use I think OCT, because OCT has a limitation. That's why
with the current generation OCT you can see, I think.
Whatever may be, but that's a procedure limitation. Suppose you are putting a ostium.
I understand.
OCT from ostium.
Yeah.
So you don't know whether if it is towards ostium, there is some micro dissection there. You cannot know with the IBUS. So you cannot know with the OCT. So left main, unless otherwise, it cannot be known by IBUS. OCT, then better to use IBUS. I think IBUS is left when you are dealing with only ostium, lady ostium. If it is a long left main, suppose you are dealing with left main to LAD stenting from the ostium only, then OCT will be okay. But if it is short left main, if the stent goes towards the ostium, so always IBUS is better.
At the end of the day, I think at the end of the day, any imaging modality that we are comfortable with, if you are constantly using IBUS, you will be good with IBUS. If you are using OCT, I think any imaging modality should be used when we are doing a left main bifurcation. That's there is no doubt in that. In all LM bifurcations, imaging is must. But it's up to the operator, and I think IBUS is an excellent choice if you are. IBUS has got a definite learning curve. The stunt opposition, deformation of the stunts is with the newer this AI This one and all, I think OCT gives excellent pictures.
OCT, yeah, OCT is there.
I
Then.
totally agree.
Okay.
So shall we move to the next presenter?
Okay, you can go. If others have doubts, you can ask.
Yeah. So, good evening. I'm Dr. Siddharth from Kolkata, RN Tagore. Let me share my screen. So, first of all, thank you for inviting me. I have been asked to show a high risk complicated PCI case, and that's why I had chose, because whenever it comes to complex PCI, a calcified lesion and handling difficult calcium always is considered to be definitely a high risk case, and this one was quite unique from that aspect, so I chose this case. In recent years, we all have a very lucrative tool, a lucrative hardware, we can say, the IVL, which helps us in handling calcium, particularly the calcified nodules and drum track calcifications. But IVL, as we are using more and more of such cases, we are finding we are getting more acquainted with the pros and cons of this tool and the characteristics of this tool, because this hardware behaves differently in different lesion. So from that aspect also, my case is something very different. So this was a 62-year male hypertensive diabetic and a CKD patient having an end-stem presentation with STT changes in ECG in the anterior walls. There was a hypokinesia in the anterior wall as well, but the patient was hemodynamically stable at present, and these are the STT changes in the anteroseptal walls, and this is the ECG. Angiogram. So now you can see that the LAD, particularly starting from the ostial part to extending up to the mid LAD, there is significant calcification. There is drum track calcification and some calcified nodules, which you can very well appreciate absolutely at the osteoproximal part of LAD. So wiring, it was not so difficult. We used a run-through wire. But initially we tried to push the OCT before we dilated to see the patency of, the channel, how what is the lumen there, and we found out that the OCT catheter was not going, so we understood that we had to pre-dilate it first and then proceed with the imaging. So we dilated with a 2.5 millimeter NC balloon, and it went easily. It was dilated from the mid part and up to the proximal, and we did the first OCT run, and this was the OCT run. You can, as we proceed towards the proximal LAD from distal, you will find that there is extensive calcification, almost 360 degree of calcification throughout the LAD, starting from mid-distal junction, mid-part, and in the proximal you can see big chunks of calcification, much more than the 5 millimeter nodule size, which we consider as a significant calcification. So we sized the IVL balloon also from here. In the narrowest segment, we found there is a lumen diameter of 2.52 around. So we decided that we will proceed with IVL, but before that we did a serial pre-dilatation with 3 millimeter NC. The 3 millimeter NC was expanding as expected, a little bit eccentrically. It was not opening properly in all the different segments, particularly in the calcified areas. So as I showed you that there was a 2.5 millimeter lumen diameter, but the vessel diameter was quite big, so we decided to use a 3 millimeter IVL balloon. and we delivered majority of the pulses, the 5 pulses, at the proximal segment where the calcium nodule was present. But the story starts from here probably, because now the IVL balloon could not be pushed further distally. This was the maximum distance which we could traverse with the IVL balloon. So as we tried again and again to push the IVL balloon, you can see that the catheters were backing out, and we were always afraid of getting the wire. The wire could have backed out and other catastrophes could have happened. But still we kept on trying, and when we found that it was no way going, we decided to use a cutting balloon first. Now at cutting balloon we could dilate at 6 to 8 atmospheres, and at some places I also went up to 10 atmospheres. You can see that the cutting balloon is going up to almost mid LAD. And then post inflation, this is very important slide, you see that post inflation, now the cutting balloon has almost become a used Oxford balloon like, and that cutting balloon also was going easily up to mid LAD. So after dilating, I was very sure that because I could daughter the LAD with this cutting balloon, I will now be able to pass the IVL balloon. But see that the IVL balloon would still not pass. Everything is stuck at the same place. The IVL balloon was stuck at the same place. The catheter was backing out again. We used further cutting balloon at slightly higher pressures, 10 atmospheres. We rotated, did multiple dilatations at the same site so that the blades cut at different planes and make some space for me. But still I could not pass the IVL. So the same story, I was really very surprised that the cutting balloon, after I used cutting balloon was I could push it distally easily. It was not much of a resistance, but the IVL balloon would not go. I tried again and again. You can see that the wire was coming out. So rather than losing all my access, I decided to deliver the remaining pulses there, because in the mid part I had already done a cutting balloon dilatation, so I have already modified the calcium there a bit, and the maximum calcification, the nodules were in the proximal LAD. So I decided that let us complete all the pulses there, and that is where we did gave all the pulses and did an OCT. Now this is the OCT run after the cutting and the IVL pulses. So you can see that there are many cracks created. Obviously the lumen is not gaining much area now, because there is some recoil also, and we need to expand it and do a stenting to see the final things. This was the mid LAD portion, that was the proximal LAD. This was the mid LAD. Because it was a long lesion, I took separate runs for a better resolution. Rather than taking a 75 millimeter run, I took short 54 millimeter runs. So this is the mid and proximal LAD, and you can see that there are cracks created as desired, more or less. So I hope that the stent would expand properly. So this was before the stenting. This was the bed preparation, and I took a 3.5 into 48 millimeter DES first in the distal LAD segment and placed it here, expanded the stent, and this was the immediate result. So the distal expansion, I think that was sufficient and adequate for me, and now I had to push the proximal second stent. And here also you can find that it was very difficult to push in the stent. That same place where the IVL balloon was getting stuck, that nodule, that same place the stent was also getting stuck. So I had to use a guidezilla. The guidezilla also would not go easily, so I used this guidezilla suction technique over a deflating balloon. When I was deflating the balloon, I was pulling the balloon and pushing the guidezilla in to suck it further distally. So that was the only possible way I could deliver the stent. The proximal stent was 2.75 into 38 millimeter, and this was the final positioning and deployment. So here also you can see that the expansion was not very optimal, but that is maximum I could achieve. I post dilated it, and this was the OCT. I used 3 mm balloon for post dilatation. IVL also used 3. So more or less the expansion and apposition was well. I did not find much of a malapposed area. So it was a long stented segment starting from proximal to mid-distal junction. And more or less you can see there are very minimal of red dots. So this was the final result, and more or less looks decent, although maybe there were further scopes of dilatation, but I could achieve this much at the best. So the take home was adequate bed preparation obviously is very important in highly calcified lesion, but the lesson I learned is that IVL is not the proper answer in all the cases. Maybe a rota in this case would have done better, or may not be rota, it was probably orbital that could have done better, because I have already created a passage with cutting balloon and all those. So rota was not a very good choice. Maybe IVL could have, the orbital could have done a better job here. But I am still not very sure why the IVL balloon was not going in spite of cutting balloon going easily. So we must have other calcium modifying tools in our kit also while handling such lesions, and obviously imaging is mandatory. So thank you for listening to my case, and if you have anything to discuss.
Thank you, Dr. Siddharth, for nice presentation and demonstration of Gargilla with balloon suction technique. Okay. The one thing is, the main problem is, as you demonstrate, calcific nodule. Okay. The calcific nodule is such a nasty thing. Even if you use OPNC also, if you full dilate, it tend to displace the normal lumen. So that's the chance of also you can get complications also. Because calcium, whatever the tool you use, you have to crack the calcium. But calcific nodule is very resistant for cracking. Okay. And just want to know, you did pre-dilate, the OCT catheter was initially not going. Initially, first. So you have pre-dilated it.
No, it was not going. It was not going.
Pre-dilated,
I prefer to use the imaging in all my cases. I prefer to use the imaging first before the first pre-dilatation, just to see the initial structure and of the lumen and the characteristic. But in many cases the IVAS or the OCT catheter doesn't pass, particularly in such calcified cases. So there it is prudent to dilate it first, make some passage, and then image.
So you dilated that segment or whole segment you dilated? And that particular calcific nodule segment?
I dilated up to mid part, but I stented much beyond that. My OCT catheter was getting stuck at the proximate junction, so I dilated that much only, because I always prefer not to disturb the calcium or other things before I could image the entire vessel. So I just dilated that segment which could negotiate my imaging catheter. So that part I dilated, I pushed the OCT, looked at the whole vessel, and then planned my next steps.
And another thing is OPNC also sometimes helps. You use cutting balloon also, because OPNC balloon you go up to 30 mm, 40 mm pressure.
Yes. I use a lot of OPNC, sir, but I find OPN a better choice in fibrotic lesions, because OPN doesn't cause too much of, it does not cause much of a cracks in calcium. So rather in fibrosis I find it more useful, and in cutting or those rota things, that shapes off the calcium much effectively. So that is my experience, and also I would say that I prefer using OPN in certain situations where after the stenting I don't find adequate expansion. So post dilatation with OPN is more effective tool than pre-dilating it with calcium. Bed preparation, I find cutting balloon a better choice than OPN. But I do use OPN a lot in post-dilating under expanded stents.
Also, they could have orbital atherectomy or rota could have better choice, because that is the IVL only limitation is balloon non-crossable lesion. And long segment also calcification, because once you dilate it, the IVL, then you cannot, you may or may not negotiate further also, because
yes, retrospectively I always think even now that orbital would have been the best choice, but I did not expect these things fast. I thought that IVL will easily go, and with 8 pulses it was at that time we did not have C2, so we had 80 pulses only. Nowadays we could have got the 120 pulses, but anyway, because we were not able to cross the balloon, 80 or 120 did not matter, so we could not have delivered the pulses mid-distally.
it's the one of the limitation of the IVL, balloon non-crossable lesion. That's the limitation. What is the stent you'll put on mid or distal segment? 3.5 or 3?
I think there was some confusion in that.
No, that was a typing error. That was a typing
that's why
error.
it looks like a 2.7.
When I was presenting, I just checked that I wrote it wrong.
Dr. Priyank, you want to say something? I'm raising hands.
Sir, very good case. Sir, just 2 aspects. My own experience with the IVL part or our team's experience. So, rather, sir, IVL is a bulky balloon. We have actually damaged one balloon just to cross it, and then it becomes very difficult in our practice to explain it to the patient that we have damaged your 3 lakh balloon. So, from then we have made it a point, particularly when we are with the calcified lesion, is to deliver it with a guideliner. And sir, in that I would like to put it across. Nipron has Guide Plus 2, which is an excellent guideliner to help you deliver anything distally. Because of the bulk, it doesn't take the shape, and that was the reason it was not crossing. So maybe Guide Plus 2 till mid LAD, and then you could have crossed it distally and come back. And the second aspect, sir, in this discussion also of calcium nodule, I have a case if time permits and if the moderator permits, we can show. The context is, sir, rota has never been as great also in calcific nodule. Maybe that is still our Achilles heel as an interventional cardiologist, because it will keep on burring like eccentrically, and the kind of expansion does not happen. So what we have, so in that IVL, my first choice is still IVL, and I don't have experience with orbital atherectomy. Maybe that might be a better option. But again, sir, post cutting balloon, we usually use a more 0.5 millimeter NC balloon just to expand it at 10 or 12, so that the superficial cuts we have made with the cutting balloon, they would deepen down, and that will expand the artery further to help deliver things. So just 2-3 personal experience points on this. Maybe
so that was a good idea to use a guide plus. I did not use IVL through that in any of my cases. So maybe next time I will try that. That was really a good idea. But I was really surprised to find that the cutting balloon was going so smoothly. It was a very smooth passage, but the IVL was not going.
It was
I don't know the exact reason for that.
It's a bulky thing which does not really fold. Maybe the cutting balloon after expansion, it takes the shape of natural of the artery. So that we have actually burnt our hands, damaging the catheter. So
that's why we always start irrespective of the localization of the calcium from distally to proximal. Always because of the bad profile after the use of the balloon. So I know that the most calcified part was the proximal one, but maybe in my cases I start distally always, because then you can't reach.
Yeah, actually I did not face such a situation before, so I thought that it was resistant to push the IVL balloon distally. So if I can deliver some pulses in the proximal part, maybe I will create some cracks and maybe it will ease my passage of IVL balloon later on. That was my thought, but I mean, I learned a lot from this case. So next time I will change a lot of my approach while using IVL in such cases.
We learned too. You get a point there as well, but every case is a different world.
It's a great case, but one point I would like to add is if our imaging catheter is not crossing, I think then better to start with rota. That is how we deal with especially long calcified lesions. If our imaging catheter is not crossing, then most likely the balloons will not cross, and IVL or orbital for that matter, the crossing may be difficult. So in such cases, starting with the rota first and then doing others may be a better idea. Maybe this is that is also a good option. But what I do till now is that whenever the imaging catheter doesn't pass, I try to pass a balloon, normal NC balloon, and if it passes, I understand that at least there is a 1.5 millimeter lumen area there, and now I could dilate it, so maybe I could save the cost, because obviously rota would add another 1 lakh, and I already had an IVL, the patient had paid for the IVL, so all those things had mattered. So but obviously that is a good approach, that if the imaging catheter doesn't pass, just bar it a little bit, make some good passage, and then proceed. Yes.
Any other comments? So I wanted to ask Dr. Ignacio, what are your choice of tools in terms of these calcified cases in Argentina? What are the prominent or go-to approaches in these type of cases?
Our approach is really similar to what you are discussing. We don't have orbital atherectomy here in Argentina. We have most experience with rota because of the costs. IVL is still very expensive. I know that in this case, the configuration with nodal calcification seems more likely to be better achieved a good expansion with IVL. So I would probably have treated this patient in the same way with IVL and imaging. But I know that it's easier for me in a cost perspective to use rotablator or rotapro.
Okay. So shall we conclude the program if no more comments are there, or anyone wants to add anything? All right. I would like to thank everyone for taking out your time for today's event. Dr. Ignacio, you might want to get back to your cases. It's still morning in Argentina. And thank you, Dr. Dhavaleshwar Sahu, Dr. Siddharth, great cases, and Dr. Srivaths, Dr. Priyank, Dr. Pradeep, and Dr. Kishle also joined us. And so the platform, this is called Interventional Insights. So I hope it was insightful for everyone. And basically, our objective is to create a platform where we can exchange ideas and gain from each other's practice. So we'll be having, this is a recurring event, and we'll be having many more of these in the future.